Hello. Today we're going to talk about mood disorders. A mood disorder is a condition where the prevailing emotional mood is distorted or inappropriate to the circumstances. Now, this chapter is going to cover depression and bipolar. The two major types of mood disorders are depression, which is also called unipolar depression, or bipolar disorder. There are four forms of mood disorders. There's major depression, cyclothymia, which is a mild form of bipolar disorder, SAD, which stands for seasonal affective disorder, and mania, which is a disorder that's characterized by being very, very exuberant, very, very hyper, very, very happy, overinflated ego, unrealistic optimism, very, overly positive. About 20% of the United States population reports having at least one depressive symptom in a given month. 12% report two or more in a year. A major depressive episode can manifest itself with a variety of symptoms. This is a disorder that it's interesting because the symptoms can actually, they are so varied, they can present opposite and still be the same disorder. Such as, you can have a patient come in to see a doctor and say, I can't sleep, I'm irritable, I'm not hungry, and I just want to snap at people. And the doctor could very easily say, well, you sound like you're depressed. Another one come in and say, I can't sleep at all. I don't have any appetite. I'm just sad. I don't have any interest in anything. That too is symptomatic of depression. So there is a variety of symptoms associated with depression that can also be in combination, and it seemed like it wouldn't be diagnosed the same, but yet it is. Actually, the term depression is often used to refer to any number of several depressive disorders. Now, we are in the DSM-5, and so I'm going to read some of these symptoms off that were from the DSM-4, but we need to go back and refer to DSM-5 for the actual updated. Things that definitely are the same. You can have dysthymia, which is a low-grade type of depression. You can have depressive disorder. You can have major depression. And so there's several that we can have. Depressive disorders can be classified by the etiology or cause. The depressive disorder due to a general physical condition and substance-induced depressive disorder. And here are some of the symptoms. A persistent sadness, anxiety, irritability, feeling of worthlessness, inappropriate guilt, feeling absolutely helpless, feeling absolutely hopeless, feeling pessimistic and negative, having a sense of restlessness, being irritable, having a foggy type of thinking, difficulty thinking, difficulty concentrating, difficulty remembering things, difficulty in making decisions. Physical symptoms associated with depression: you can have an increased appetite or you can have a decreased appetite. You can have insomnia, where you can't go to sleep or you can't stay asleep, or you can have where you want to sleep all the time. There's also symptoms that would be decreased energy, feeling fatigued, feeling slowed down, sluggish, headaches, digestive problems, chronic pain, even possibly feeling agitated or slowed down. Wanting to withdraw and isolate is a very characteristic symptom of depression. Wanting to not be involved in family gatherings, family activities. Thoughts of death or suicide are very common. Depression or unipolar depression includes subtypes of major depression. That would be like single episode, major depression recurrent or multiple episodes, major depression with psychotic symptoms, dysthymia, postpartum depression. A major depressive episode has been defined as a severely depressed episode, mood episode that will persist for at least 2 weeks. Also, always in the back of your mind, remember, if there is a symptom or a disorder that interferes with day-to-day living, with your day-to-day living skills, that's indicative that there is also a problem. Episodes can be isolated, just having one, or recurrent. They can be categorized as mild, where there's very few symptoms, moderate, or severe. Now, the severe will have a major impact on the social functioning, not wanting to be around anybody, occupational functioning. It can interfere with your job. When you have a psychotic episode, it will automatically be rated as severe, and this psychotic episode will be associated with delusions and or hallucinations of break with reality. All right, we have, many of the therapists will talk about a type of depression that is, it's associated with grief. Now, this is not listed in the DSM-5, and so when you have somebody who has a loss, and they respond by having feelings of depression and feelings of heavy grief, technically, even though the therapist can classify it as a form of depression, it's really not an actual DSM-5 category. Some of the subtypes of depression: melancholic depression. This is characterized by anhedonia, which means not being able to experience pleasure. And that would be in some, most, or all activities. A failure of reactivity to pleasurable stimuli, okay? Now, another thing about the melancholic depression, it's a quality of depressed mood that's more pronounced than grief or loss, okay? It's a worsening of symptoms in the morning hours and in the early morning awakening. There'll be psychomotor retardation, excessive weight loss, not to be confused, it's not the same as anorexia nervosa, or excessive guilt. Now, what's called atypical depression is actually a fairly common type. It's characterized by mood reactivity, positivity, significant weight gain, increased appetite, comfort eating, excessive sleep, hypersomnia, latent paralysis, significant social impairment as a consequence of hypersensitivity to the perceived interpersonal rejection. Contrary to its name, atypical depression is the most common form of depression. Psychotic depression is the term for a major depressive episode, usually associated with melancholic depression, where the patient experiences psychotic symptoms such as delusions, which is a false belief, or less commonly, hallucinations, which is a false sensory experience. These mood congruent content coincident with depressive themes as non-mood congruent symptoms are more suggestive of schizoaffective disorder. Now, catatonia depression or catatonic depression, this is a very rare form of major depression. It involves disturbances of motor behavior and other symptoms. Postpartum depression is listed as a course specifier in the DSM. It refers to intense symptoms that follows having a woman having her giving birth to a child. It's intense, it's sustained. Sometimes it can actually be disabling, and it's a form of depression. Postpartum depression, which has an incidence of about 10 to 15%, typically sets in within 3 months of labor and can last as long as 3 months. Dysthymia. This is a chronic, milder type of mood disturbance where a person reports a low mood almost daily over a span of at least 2 years. The symptoms are not as severe as those from major depression, although people with dysthymia are vulnerable to second episodes of major depression, sometimes referred to as double depression. Now, dysthymia is kind of a low-grade type of depression that just kind of stays with you, that's under the surface, I would say. Recurrent brief depression. This is distinguished from major depressive disorder because of differences in duration. Patients with recurrent brief depression have depressed episodes about once per month, and they have individual episodes lasting less than 2 weeks and typically less than 2 days, 2 to 3 days. The diagnosis requires that the episodes occur over a span of at least 1 year and in female patients independently of their menstrual cycle. We have minor depression. This refers to a type of depression that does not meet the full criteria for major depression, but it does have symptoms that are at least 2 weeks, and there are at least 2 symptoms present. Now, there is a type of mood disorder that's called adjustment disorder. Now, adjustment disorder with depressed mood is the name given for a psychological response from an identifiable stressor or stressors that causes significant emotional or behavioral symptoms, but it does not meet criteria for more specific disorders, major depressive disorder in this case. Most experts believe that both biological and psychological factors play a role in depression. It looks like there is a family component that links genetics to depression. It looks like the degree that it's genetically determined can be estimated at about 40% for women and 30% for men. The exact cause of depression is not known. We do believe that heredity has a role in it. How much of a role, we're not sure, but it does have a role in it. People who have a history of child abuse or other life stressors, they have the biological capacity to be twice as likely to develop depression as those who have not. There may be a link between depression and neurogenesis of the hippocampus. The hippocampus is a center for both mood and memory. Loss of the hippocampal neurons has been found in some depressed individuals, and it will correlate with impaired memory and dysthymic mood. Now, drugs may increase serotonin levels in the brain, and a lot of them do this by increasing the uptake of serotonin. They do this by inhibiting it's called serotonin. The medications are serotonin reuptake, serotonin reuptake inhibitors. And it causes the neurons to let the serotonin stay out in the synapse longer so that they can find receptor sites and hook into them, and therefore the person gets more serotonin. These drugs, they can increase the serotonin levels. This stimulates the neurogenesis, and then this will increase the total mass of the hippocampus. This increase may help to restore mood and memory. Now, depression can also be caused by an overactive hypothalamic pituitary adrenal axis. This resembles the neuroendocrine response to stress. This HPA axis, the abnormalities that occur, participate in the development of depressive symptoms, and antidepressants serve to help regulate this HPA axis function. Depression can be affected by variations in circadian rhythm, the REM the REM stage of sleep, in which dreaming occurs, tends to be especially soon to arrive and especially intense for people who are depressed. So, although the precise relationship between sleep and depression is mysterious, we don't know, it does appear to be strong and among those whose depressive episodes are not precipitated by unusual stress. Therefore, in these cases, clients may be especially unaffected by therapeutic intervention. Therapies. Well, I can tell you that a lot of therapists will use cognitive behavioral therapy. Doctors will use antidepressants, okay? Now, the SSRI, the selective serotonin reuptake inhibitors, such as Zoloft, Lexapro, Prozac, Paxil, and Celexa, they are primary medications considered for patients because they, as far as antidepressants go, they're fairly mild in side effects. They do have a broad effect on depression and anxiety. When everything else has failed, all the therapy, all the medications and such, the doctor may start looking at what's called electroconvulsive therapy, ECT. That's the shock treatments. Now, these are not as brutal as they were many years ago. They've been much, much more refined. But there are some, even though they are effective in some cases, they also have some downsides. We had a patient that we used to call the poster girl for ECT. She came in and was sobbing 24 hours a day, sobbing so hard she couldn't eat, she couldn't drink, all she could do was sob. Well, if you think about that, that is a case that's very ripe for somebody to become dehydrated and malnourished because they can't eat or sleep or drink. The doctor tried different medications, tried to get some on board. Some of them were successful in getting on board. Some of them were not, but none of them were successful in alleviating the 24-hour sobbing. The therapy was not helping. The doctor came in to the team and he said, "Okay, what are we going to do?" And the team decided that they would try electroconvulsive therapy. The lady underwent her first shock treatment, and that afternoon she went from sobbing to just crying. The next ECT, she went from crying to whimpering. The next ECT, the crying, whimpering completely stopped, but she was still very depressed. On the next one, after the next ECT, she began communicating with people. By the time that she left the hospital, she was restored, where she was communicating, talking with people, laughing, and the ECT worked tremendously well in her case. The downside, usually after somebody has an ECT treatment, they're going to have a complete lack of memory for about 5 to 6 hours. They will not be able to remember anything. Another downside, once you have had one shock treatment, there is an extremely high possibility, or likelihood, I should say, that you will have to have another one. If you after you have had many, many rounds of your ECT, and that means like you get this group, and then after several months or years, you get another group, and then after another time, you get another group. Over time, that will affect a person's memory in general. Prognosis. Well, first of all, once you have had a major depressive episode, you're highly likely to have another one. Depending on how severe the episode is, how long the person has been depressed, that will figure into the prognosis. Dysthymia is a mood disorder that falls within the depression spectrum. It is considered chronic, but it's less severe. This is the one that I said is kind of a chronic underlying milder form of depression. We've already talked about that. The dysthymic may sleep too much. They may have trouble sleeping. They may have trouble concentrating. They may be decisive and tend to be pessimistic. They might even have a poor self-image. The symptoms can grow into a full-blown episode of major depression. Dysthymia is more constant. It will last for longer periods, and sometimes it'll begin in childhood. It can result as a person with dysthymia tends to believe that depression is part of their life, of their character, of their personhood. It is 2 to 3 more times common in women than men. People with dysthymia experience a major, sometimes people with dysthymia have experienced a major loss in childhood, such as the death of a parent. Others might describe being under chronic stress. It's often difficult to tell whether people with dysthymia are under stress or more stress than other people, or if the dysthymia causes them to perceive and react to stress differently than others. The essential symptom involved, it's the individual feel depressed almost daily for at least 2 years. They will have low energy, disturbances in sleep, disturbances in appetite, a low self-esteem. Typically, all of these will contribute to the clinical picture. Sufferers often will have experienced dysthymia for many, many years before it's diagnosed. Let's talk about suicide for a minute. First of all, let me dispel any kind of myth that you have heard that said if somebody is talking about suicide, they're not serious. That if they call you up and tell you, I think I'm going to commit suicide, they're just trying to get attention. Sometimes this is true. You can't take a chance because sometimes it's not. Let's put it like this. If they are thinking about it, they need to see a physician. They need to see a doctor. If they're talking about it, they need to see a doctor. If they're talking about it, then they're thinking about it, and there you go. There are some things that the doctors look for when they are getting an idea about the depth of the suicide ideations that the person's having. You ask the person, do you have a plan? Now, a lot of your doctors and a lot of your people will say, you know, you can ask them and it's not going to cause them to commit suicide because they're already thinking about it. Well, to tell you the truth, in my experience, they lie. And you can ask them point blank, are you thinking about suicide? And they'll say, oh no, and then they'll go out and try and do it. Normally, what I would do is I would say, if you ever decided to hurt yourself, how would you do it? That tells me if they've been thinking about it, that tells me if they have a plan, and then we've got something to go on. That means that do they have what it takes in their plan to commit suicide? So if I were to say, have you ever thought about committing suicide? And the guy says, well, yeah, I've been thinking, you know, if I were to do that, I think I'd get on top of my Harley Davidson, drive out into the interstate and get in front of a 18-wheeler and then slam on my brakes. Well, because he has a Harley Davidson, now I know he's got a plan and the means. Okay, so that really elevates his suicide potentiality. Okay, have they got a family history of suicide? They can never have a person in their entire ancestry committing suicide, but once a person in that family commits suicide, it raises the risk factor for everybody. Do they have a history of depression? Do they use drugs or alcohol? You do not have to be an alcoholic or a drug addict. Do they use it? Because if they use drugs or alcohol, that can lower ambitions, that can boost their courage, and give them a false feeling that they have the ability to carry it through. Have they ever made a prior attempt? If they have, that raises the risk factor. Have they started giving away prized objects? I know somebody who got a call at 6 o'clock in the morning, and this fella, his best friend called him and told him, you know, I know that you would really, really love to have my remote control plane. I know that you would enjoy it as much as I have, and I'm not going to have a need for it anymore, so if you look out in your driveway, it's parked in your driveway. Sure enough, the guy looked out there, and there it was. Knowing that this fella had been very, very depressed, had had a significant loss in his life, had been drinking, he immediately started looking for his friend. He really felt like this friend could very well be suicidal. He found him, thank goodness, in time. The guy was sitting in a truck, in his pickup truck, drinking alcohol with a gun in his lap. Are they giving away prized objects? Now, the next one's kind of iffy. You know, if you have somebody who's older and starts getting their estate in order, then that may or may not be an indicator. But see, the people that are senior citizens, they have one of the highest suicide rates. So now you have to look at that and say, well, goodness gracious, are they suicidal or just planning for when they pass? That's when you look at the list and see, do you see any more of these indicators? If you have a teenager that starts wanting to inquire about getting a will in order, does the family have funeral arrangements and such, that might be a red flag to look into. With that being said, we're going to close out the depression part of this, and then the next one we'll talk about bipolar. I hope you enjoyed it. Have a great day.